Welcome everyone. My name is Monika Pilch and I am the chair of the Early Career Researcher Forum Committee. On behalf of the committee, I am delighted to welcome you to the ECRF abstract presentations. The ECRF is multidisciplinary in nature and includes early and mid-career, palliative, and end-of-life care researchers. Our goal as the ECRF committee is to provide support to our members and create opportunities for research capacity building and the share of knowledge across disciplines. Along with All Island Institute of Hospice and Palliative Care, we foster a strategic approach to palliative care research and knowledge development on the island of Ireland. We currently have 146 members. Given this expansion, we have recently created new roles within the ECRF committee to include the role for the networking officer, who will aim to establish collaborative links with early and mid-career researchers nationally and internationally. We are proud to say that ECRF committee developed a comprehensive action plan in January this year and has facilitated many activities since. In September, we launched ECRF quarterly newsletter and ECRF podcast series. Both are available on the Institute's website, and their Christmas editions will be released in December. In January next year, we will launch Stress First Aid presentation, aiming to equip researchers with coping skills for conducting research in challenging times and contexts. Keep an eye out for information relating to the upcoming events, and please circulate to your networks. As part of our growing collaboration with the Palliative Care Research Network, we are delighted to showcase some of the excellent research conducted by early and mid-career researchers today. We are looking forward to their presentations.
Hello, my name is Anne Fee, and I'm here today to present to you an overview of our systematic scoping review about the role of healthcare assistants in out-of-hours community-based palliative care. This review was undertaken as part of a larger study at Ulster University, which was funded by Marie Curie UK. And the aim of the current review was to identify the roles, responsibilities, contributions and policies relating to healthcare assistance in out-of-hours community palliative care. So by way of background then, healthcare assistants are also known as support workers or unregulated care providers or nursing auxiliaries. They're employed in a variety of settings, including hospitals, hospices, and within the community. And the care they provide can include personal care, assistance with medication and wound care, mobilisation and emotional support. Prior research has indicated that daytime healthcare assistants within palliative care they play an important role, but they're rarely recognised as an integral multidisciplinary team member. And their role in out-of-hours community-based palliative care is largely unknown. So we undertook a search of 5 databases and we identified 2,854 papers. After the removal of duplicates and review by title and abstract, this left us with 105 papers. And whenever we applied inclusion criteria, there were 6 articles. 3 from the United Kingdom and 3 were from Canada. So the data was analysed thematically using Braun and Clark, and we identified 2 main themes in the literature. The first one was roles and responsibilities. And although all of our 6 selected studies alluded to roles and responsibilities of healthcare assistants within community-based out-of-hours care, only really one of them focused on this specifically. And this was McPherson et al. In 2019. And they reported that the role centred around patient care, helping out around the home, and providing support, social support to the patient, family and caregiver. And the frequency of the healthcare assistant's presence in the home enabled them to monitor the situation and the patient status and family status, and they could alert other healthcare practitioners in order to get more care if that was needed. McPherson et al. Also looked at challenges involved in this role, and they identified that there was incompatibility between healthcare assistant competencies and patients' needs. There was some issues around emotional attachment, and there was also issues around undertaking tasks that were beyond their remit. The second theme in the data was contribution to care. And this was specifically to do with contributing to enabling the patient to stay at home in order to die, as this was their preferred place of death. Two papers alluded to either direct or indirect contribution to care in this respect. Butler et al. Talked about the existence of a rapid response service within their area, and they found that patients who accessed this service had double chances of remaining at home in their last days of life. In addition, McPherson et al. Talked about an indirect contribution to care, and they said that the existence of a healthcare assistant role within the home, undertaking tasks such as meal preparation or perhaps helping out with laundry, enabled a sense of normality to remain in the home, and also enabled caregivers to spend more time with the patient during the end of life. Over and above these two themes, there were no specific policies found that related to the healthcare assistant within out-of-hours care. So by way of discussion then, our review revealed only limited findings, and this was due to the introduction of the out-of-hours component in our search. This is interesting given that prior research has indicated that 30% of patients will have contact with out-of-hours services in their final days of life. And also that it's important that we address this because 2/3 of the week are within an out-of-hours context. Having said that, generally papers indicated that healthcare assistants played an important role in out-of-hours community-based palliative care. And this was especially to do with monitoring and responding to patient and family physical and emotional needs during this time. McPherson et al., however, emphasised that very often healthcare assistants would undertake roles that were beyond their remit, and it's not really clear why this happened. It could possibly be because there just wasn't enough other care or paid social care to fill this role. Alternatively, this could point to inconsistencies in the healthcare assistant's role and responsibilities and unclear expectations about the role from families or from other healthcare team members. So in conclusion, there's an increased international emphasis in care in the community, and it's been suggested that out-of-hours care contributes to integrated palliative care and is integral to facilitating death at home. Given this and the current COVID-19 global pandemic, it's really important that we increase our understanding of the healthcare assistant within an out-of-hours context in order to meet their support needs and also to plan efficient future out-of-hours care. And finally, findings in this review reveal a significant gap in literature and signify the need to examine the reasons why the healthcare assistant role is undervalued, and also why policy has failed to recognise their contribution to out-of-hours palliative care. So thank you so much for listening to my presentation today. There is information on the slide here about the paper if you want to read the full paper, and I'm happy to take questions or comments or thoughts about our contribution to this very important area. Thank you. Goodbye.
Good afternoon. I'd like to start by thanking the Institute and the organisers for giving me the opportunity to speak to you today. My name is Cleona Lorton, and I'm locum consultant in palliative medicine at Our Lady's Hospice and Care Services, working with the community palliative care team. I'm also completing my PhD in cancer-related inflammation. But today, I'm going to talk to you about people with dementia being seen by our specialist community palliative care team. So the background to this is that palliative care is pretty much accepted as an essential part of dementia care. And indeed, most countries worldwide which have a dementia strategy refer specifically to palliative care in that strategy. Indeed, in Ireland, we have our Irish National Dementia Strategy since 2014, and that has multiple mentions of palliative care. However, most of these documents don't draw a distinction between specialist palliative care and a palliative care approach. Now, Kelly and O'Connell looked at data from Sligo and referrals to a specialist palliative care service there back in 2012, and they found that 15% of their referrals had dementia. A very recent systematic review, only published in the last month, looked at the integration of palliative care in dementia services and indeed found a trend to benefit. But very disappointingly, they did not distinguish at all between specialist palliative care and a palliative care approach, making it difficult to know what the relevance of that is to our services and indeed how we should be changing, if at all. So I wondered, what is our current practice? What's happening now on the ground? And so I set out to look at the current utilisation of our community palliative care team service by people with dementia and their families. So the method, well, this was a very straightforward case note review. I looked at all patients who were being seen by our team on the 6th of November 2020, and from the electronic and paper record, extracted information on demographics, comorbidities, number of medications, functional status, their activities of daily life, their performance severity score, and symptoms in line with the Australian Palliative Care Outcomes Consortium. And I also looked at referrals and links with other services. So to the results. Well, of 198 people being seen by our service at that time, 11 had dementia. Now, of those, 6 had dementia as their main diagnosis, while for 5, they had it as in addition to another diagnosis. All, interestingly, were at home. 6 were male and 5 were female. Median age was 88, with a range from 73 to 92. Median number of comorbidities was 7. And concerningly, median number of medications was 10, with a range between 3 and 13. Performance status, as measured by the Australia Modified Karnofsky Performance Scale, which gives the measurement in percentages, median was 40%, with a range of 20 to 60. As for activities of daily living, 9 of the 11, so almost everyone, had quite a high dependence score at 10 or more. As for symptoms, 2 were reported as having pain. This may seem like perhaps less than we might expect. Other symptoms, however, were reported in 8. Psychological and spiritual problems were noted in many, 6. And family and carer problems were almost ubiquitous at 10. So how about referrals? Well, of those 11, 5 had been referred by their GP and 6 had been referred by a hospital palliative care team. Interestingly, none had been referred by medicine for the elderly, geriatric services, or by psychiatry for the elderly services, despite the fact that 8 had actually been seen or were still being seen by those services. And during the person's care with us, only one time had we discussed their care with either psychiatry for the elderly or care of the elderly medicine services. So in conclusion, this data provides a brief snapshot of current utilisation of our specialist palliative care community service by people with dementia. Psychological and spiritual problems were high and family carers were extremely common. Concerningly, polypharmacy was very prevalent. So what next? Well, back in 2005, Sampson et al. In a systematic review concluded that there really was little evidence at that time to tell us how we should to devise a framework to develop services. And some progress was made a couple of years ago, and that's reported in Fox et al. Report the proceedings of a workshop, and that was reported in 2018, and they identified some research priorities in this area. But really there isn't a whole lot to guide us, and there's an urgent need for more research. Looking at our own practice, I would argue that given that many different services are and have been involved, there is certainly scope for increased collaboration and conversation between the different services involved in a person's care. So we can say that we truly are providing person-centred care with the best of all, with different services perhaps dipping in at the different times when they're needed. So I'd just like to acknowledge Dr. Clodagh Power, registrar, a specialist registrar indeed, in psychiatry, who's going to look further into our data from 2019 of people with dementia. And I'd also just like to acknowledge my colleagues in the community palliative care team for all their work. Thank you.
Hello, I'm Julie Goss, an AMP in palliative care at Our Lady's Hospice and Care Services. This presentation will describe the redesign and evaluation of an AMP-led multidisciplinary breathlessness support service. The service is for patients with chronic refractory breathlessness and their carer, and it is based in the outpatient hospice setting. Chronic refractory breathlessness is described as breathlessness at rest or with minimal exertion that exists despite the optimal management of the underlying disease. It is a frightening and burdensome symptom with a high prevalence of up to 78% of those with advanced lung cancer present in many disease groups, and for example up to 95% of those with advanced COPD. It's an underassessed and therefore an undertreated symptom, and the literature describes that oftentimes there may be a focus of healthcare interventions on management of the underlying disease at the expense of the management of symptoms such as breathlessness that are causing such an impact on quality of life. The existing breathlessness management programme at Our Lady's Hospice and Services was a service innovation led by a previous AMP set up approximately 10 years ago. This service model involved an initial holistic palliative care assessment by the AMP and follow-up visits for 6 to 8 weeks, where the patient was reviewed on each visit with a separate appointment with each of the AMP, the physiotherapist and the occupational therapist. While informal feedback of the programme was excellent, the service required considerable clinical resource and also a significant time commitment from the patient perspective. In recent years, emerging evidence has demonstrated that briefer breathlessness intervention models can reduce distress from patients with advanced disease. Therefore, a multidisciplinary review and restructure of the service was initiated by the AMP of the current service. The first steps taken for service redesign were a literature review and liaison with local and national key stakeholders and also with international opinion leaders. This was undertaken by the AMP. After collation of this information, key members of the MDT reflected on the current service iteration and were actively involved in service redesign. A renewed 5-week service called the Multidisciplinary Breathlessness Support Service, or MBSS, was designed. This had a rehabilitative palliative care ethos and also, importantly, a supported self-management framework. The service then involved initial holistic palliative care assessment plus 3 on-site individual clinician consults. This built on the foundations of the existing programme and included primarily non-pharmacological individualised interventions. Examples of these are on the left-hand side of the slide. Referral criteria included chronic refractory breathlessness, which the patient was bothered by, optimised medical treatment and ability to engage in a self-management programme. Volunteer transport was offered to those who would have had difficulty accessing the service otherwise. And the intervention was supported by a comprehensive resource manual, a CD, a relaxation CD, patient education materials and pedometers. Staff undertook a 2-day motivational interviewing training, and this was really highly evaluated. The School of Nursing of Midwifery and Trinity College Dublin were then invited to evaluate the effectiveness of the new service, and a programme of promotional activities ensued to raise awareness of the service with the community and acute care organisations. So for the pilot period from March to July 2019, 49 patients were referred to the service, and the most common diagnoses of those referred were advanced COPD, idiopathic pulmonary fibrosis and lung cancer. Of these, 21 only were eligible for the service, and 10 service users participated in a longitudinal mixed method study. This entailed completion of a questionnaire at T1 and T2, which included breathlessness measures and measures of healthcare experience, and then a subsample of 8 service users, 2 referrers and 1 carer were interviewed after T2 to discuss their experiences of using the service. So the findings of the study, service users reported significant improvements in mastery of their breathlessness, which was our primary outcome, and also in fatigue and emotional well-being. And while there was a downward trend in breathlessness scores, these didn't reach statistical significance. This is consistent really with international research, and there's been a more recent move to look at different outcome measures, such as functional outcome measures in breathlessness research, to better capture the benefits of services. Participants rated the service as excellent. There was 80% of participants, 20% rated very good, and 100% of participants said that they would use the service again if required or recommended to somebody else experiencing breathlessness. And during interviews then, service users described the burden of their breathlessness and also acknowledged that they valued the support with navigating wider system issues. And this aspect of the service stemmed really from the holistic palliative care assessment, and it did provide a challenge as regards from a time perspective in the context of delivering a brief intervention. And factors that were identified as supportive were providing resources and supports, and that included transport to appointments and equipment to support self-management, which was very much valued by service users. Clinicians really valued the training in motivational interviewing, identifying it as a key factor in helping support self-management interventions. The evaluation did identify a discrepancy between key referrers and clinicians delivering the intervention around timing of the referral, with palliative care clinicians preferring to meet patients earlier in their disease trajectory. Some misconceptions also were identified around the role of hospice palliative care, the use of opioids, and also it was very much highlighted the need to further integrate this service into acute and community care services, and the opportunities that exist around linking with social prescribing networks. And so to conclude, refractory breathlessness is a distressing symptom that impacts on the individual and the family. And person-centred brief interventions to enable breathlessness self-management are feasible and positively in this incidence impacted mastery, fatigue and well-being. MDT reflection and evidence-based renewal and evaluation of a pre-existing service led to an effective reiteration of a service, and future developments will focus on service configuration and further integration. Further work in our example will also address any potential misconceptions of service users about hospice and palliative care by further developing our service information leaflets. And future work will also focus on activities to enhance service awareness of our referral criteria and to communicate the benefit of the MBSS when delivered in tandem with acute and community services. I will finish by highlighting the quotes on the slide above in orange from patients, which demonstrate their perceptions of the valued aspects of the service. And so thank you for listening, and thank you to all the team at OLH and Hospice and Care Services, and to TCD, and most importantly to all the patients who took part in this research. And if you have any questions, I can be contacted on the email on the title slide, and the in-depth evaluation of this service will be available on the TCD Tower repository at the end of the month. Thank you.
Hello, my name is Dr. Niamh Cleary. I'm currently working as a clinical tutor in the Academic Department of Palliative Medicine in Our Lady's Hospice and Care Service in Harold's Cross. Thank you for the opportunity to present today, and I'm presenting a service evaluation of an initial assessment pro forma in a community palliative care team. To give you a little bit of background in our organisation, when a patient is first assessed by a member of the community palliative care team, a detailed and extensive initial assessment is undertaken using a 12-page pro forma. The aim of using this is to comprehensively review and identify the physical, social, spiritual and psychological needs of a patient. A 2-page consolidated proforma was devised for use in patients who were referred to the service who were anticipated to die within 72 hours of referral. These patients and their families and caregivers may require significant medical or emotional support during this visit. The purpose of the consolidated proforma is to optimise the time spent with the patient and their families. The document was reviewed by a service development group and updated in December 2019. This is a service evaluation of the use of an updated version of the consolidated initial assessment proforma used in patients who have been referred to CPC2 and who are anticipated to die within 72 hours of referral. A retrospective chart review was carried out on patients referred to the service between the 1st of January and the 14th of August 2020 who died within 72 hours of referral. Ethics approval was not required as this was a service evaluation only. 48 patients were identified to have died within 72 hours of referral. 41 charts were available for review, 5 charts were still in use by administration, and 2 charts only had 1 volume of clinical notes available at the time of request. 3 questions were identified for evaluation. 1 was the 72-hour proforma used, 2 what was the prognosis indicated on the referral, and 3 was there a documented conversation with the referrer or family member indicating urgency of the referral. 17 charts had used the 72-hour proforma. 23 used the standard initial assessment proforma. 1 chart had no assessment filled as the patient died on arrival of the clinician. A prognosis of days was indicated in 18 of the referrals. 10 had weeks, 3 had months, 7 had no prognosis indicated at all, 2 had weeks to months, and 1 had unknown. 34 of the referrals were accompanied by a phone call by either the referrer or a family member to the service. When a patient is first assessed by CPCT, a thorough and comprehensive assessment is undertaken to identify and gather information on an individual's physical, spiritual, social and psychological health. This reflects the WHO definition of palliative care, which includes an impeccable assessment. Taking a comprehensive and accurate assessment allows for early identification and prompt response to meet an individual's palliative care needs. Furthermore, the WHO definition of palliative care includes offering a system of support to help an individual's family cope during the individual's illness and bereavement. When a patient is referred to a community palliative care team for specialist palliative care needs in Ireland, the referrer must complete the National Standardised Referral Form and they must indicate the urgency of the referral and an estimation of prognosis. Numerous studies have identified that clinicians are often repeatedly inaccurate in predicting prognosis when they rely on their clinical experience and intuition alone. Accurate prognostication is valued by palliative care patients and their families. When a prognosis is identified as being short and an individual is referred to a specialist palliative care team, the individual and their family need prompt and timely specialist physical and emotional support. As a result, in our community team setting, a 2-page consolidated initial assessment proforma was devised for use in patients who were referred to the service who were anticipated to die within 72 hours of referral. These patients and their families may require significant medical, for example, setting up a syringe driver, responding to physical symptoms like pain or repositioning, or emotional support during this visit. The purpose of the consolidated proforma is to optimise the time spent with the patient and their families. It facilitates a focus on the practical and emotional aspects associated with end-of-life care. The document was reviewed by a service development group and updated in December 2019. It is unsurprising that only 17 of the 41 charts had a 72-hour proforma assessment, as an analysis of the prognosis indicated on the referral form reflects this, i.e. 18 referrals had a prognosis of days indicated. The variation in prognosis as predicted by the referring clinician reflects the inaccuracy of clinician prognostication when often there is an overestimation of prognosis. However, 34 of the referrals were accompanied by a phone call from the referrer or a family member. A limitation of this evaluation was that it was only recorded if either the referrer or a family member made contact with CPCT, and not a breakdown of how many were from the referrer or the family member. It is difficult to ascertain the significance of this, as often a family member will phone in distress, reflecting carer burden, psychosocial distress, or poorly controlled symptoms rather than impending death. A flow diagram was then devised to trigger the consideration of the 72-hour proforma used by CPCT staff. It is by no means a fixed algorithm and is recognised that clinical situations are not always clear-cut. In conclusion, this was a service evaluation of the use of the updated 2-page initial assessment proforma used by CPCT in patients who die within 72 hours of referral to the service. A flow diagram was devised to trigger the suitability of its use. It did not capture patients who may have had the assessment used and live longer than 72 hours. This could be the focus of future audit. Thank you.